go ahead and get started. So tonight is the case study portion, kind of as a carryover from last week. So I guess you can advance. I'm Kristy Delaney, for those of you who don't remember, nurse practitioner with KU Medical Center, University of Kansas. These are our sponsors. And then, so this is just kind of the title. We're going to go ahead and get started with, we have 2 case studies tonight, and we can go ahead and advance to the first one. It's about a patient with rheumatoid arthritis. Okay, so this gentleman is a 67-year-old male. He presents to, I believe, his primary care with just some fatigue and some shortness of breath, exertional shortness of breath over the past 6 months. Doesn't really know what's going on. And so they do note that he had been diagnosed with seropositive rheumatoid arthritis, which means that he did have a positive rheumatoid factor about 4 years ago. Those are his labs that you can see. So his rheumatoid factor was quite high, over 300, and his anti-CCP antibody was over 60. He had been started on methotrexate, and then as well as adalimumab or Humira had been added a couple of years ago because he had continued to have some ongoing disease activity. So from a pulmonary perspective, what features does he have that are going to kind of raise some flags or raise concerns that he's going to have a higher risk for developing interstitial lung disease? And since don't have anyone, I'm going to say that from my perspective, the features that I see are his age of 67, the fact that he's a male, a high titer anti-CCP antibody, and a high titer rheumatoid factor are all risk factors. So upon evaluation, his primary care did notice some inspiratory crackles when she listened to him with her stethoscope. And then on vital signs, he did have a normal oxygen saturation when he was at rest, but they did do a walk test in the office and he desaturated. So that is significant. The chest x-ray, they got a chest x-ray and it did show some interstitial markings. And so the primary care decided to go ahead and order complete pulmonary function tests as well as a high-resolution CT scan. The PFTs showed a restrictive lung disease with a FVC or forced vital capacity of 65%. And then he also had a pretty severely impaired diffusing capacity with a DLCO at 41%. The CT scan showed as you can kind of read the radiology interpretation, but he did have what's called a UIP pattern. He had reticulation and honeycombing on the CT scan. So what would be the next kind of step or what would be the next recommended thing in the guidelines for someone with rheumatoid arthritis that now has interstitial lung disease? And I believe that the next step would be a pulmonary referral if they weren't already seeing pulmonary. So he got a referral to pulmonary, and at that office visit, they did confirm that he did in fact have rheumatoid arthritis-associated interstitial lung disease with what we call a UIP phenotype, meaning that is the pattern on the CT imaging. And so he had been on methotrexate for 4 years, and then, like we had discussed earlier, he'd just been on the adalimumab for about 2 years. So those were all, we kind of went through this already, but that third kind of line shows those are all factors that are considered high risk for this gentleman. So then the question would be, what do you do next? So what baseline follow-up exams, things like that would you want to do? And then do you want this patient to continue on methotrexate? From my perspective in my practice, what we would want to do is to get pretty routine pulmonary function tests, every probably every 3 months initially, and if they stabilize out, sometimes we can space it out to every 6 months. But you definitely wanna see them regularly. With the lung function test, you also wanna do regular exams, take a listen to them, see how they're feeling, symptomatically, are they progressing or not? The other thing I'd like to note is since he had a desaturation with walking, I would wanna get well, we call it an exercise oximetry or like a 6-minute walk test with an oxygen titration. And with that low of a diffusing capacity, I would also be inclined to get an echocardiogram to screen for pulmonary hypertension. Um, as far as the methotrexate goes, it can be somewhat controversial, but there is some data to suggest that methotrexate it does have pulmonary toxicity, and so people with that UIP pattern, oftentimes we wanna switch them to something else. So that is, if you go to the next slide, I believe that is in fact what they do. So they did switch him to a Betasept, which is Orencia. They also decided to start him on nintedanib, which is an antifibrotic medication, one of the ones we talked about last week. He was already on some low-dose prednisone and potentially for joint pain control. They don't really tell us here. We always recommend that they stay up to date on their vaccines, especially the ones that protect their lungs. So we like to ensure that our patients are up to date on pneumococcal, influenza, and COVID-19. And then the most recent one that's out is the RSV vaccine. So if they qualify for that, we do also recommend that one. And as this says, so the monitoring the PFTs every 3 to 6 months, like I just discussed, and then we do repeat CT scans roughly every year. It does also kind of depend on some of their history and things like that. So what evidence supports starting the antifibrotic or the nintedanib in this patient? And it is that they had that UIP pattern on imaging. In terms of what biologics might be preferred, I would say rituximab is a great choice for a biologic that helps to control the joint disease as well as the lung disease. Tocilizumab is another good medication that we use as well for both. So to summarize this case study, the high-risk rheumatoid arthritis patients, we do need to pretty proactively monitor them and screen them for interstitial lung disease, really paying attention to symptoms, putting your stethoscope to their lungs, listening, taking a good history, good exam, all of that. As far as how do we identify things early, not just based on symptoms, but, getting those complete pulmonary function tests and a high-resolution CT scan just for that early identification. Again, this UIP pattern on imaging is associated with a poorer prognosis. It's usually pretty advanced disease once it gets to that point. But we do use antifibrotics to slow the rate of decline. Now, antifibrotics don't reverse the scarring process that's already happened, but they can slow it down. And then just kind of having that shared decision-making, making sure these patients are following regularly with both rheumatology and pulmonary is essential just to full holistic care. Okay, so case study number 2 is going into a patient with systemic sclerosis. This is a 56-year-old female. She has noticed some worsening shortness of breath over the past 6 months, as well as a dry cough. She has already been diagnosed with diffuse systemic sclerosis, and we kind of talked about last week the differences between diffuse and limited. But she had been diagnosed with diffuse for the past 2 years. So, some of the features just to note is that she had had some skin thickening proximal to her elbows, um, and then as well as Raynaud's and some GERD or reflux. She did have a positive antibody, the SCL70. And then, so the question is, what is her risk of developing ILD? With diffuse systemic sclerosis, it really is about 50%. It's a pretty high percentage of patients with this disease process that do go on to develop ILD. So we need to monitor these patients very, very closely. As far as baseline screenings, you always want to get a chest. Well, in order to get a CT scan approved, oftentimes we need to get a chest X-ray. So especially with anyone with any sort of respiratory problems, ensure that they've had a chest X-ray, and then a high-resolution CT scan would be the next step, as well as baseline complete pulmonary function tests. So in terms of her ILD, she had noticed, worsening over a 6-month period of time. She also did show some desaturation on exertion, so we need to be careful there. These are her PFTs, so her forced vital capacity was about 71%, so that's only mildly impaired. But that DLCO at 52% is more severely impaired, kind of moderate to severe, and they tell us that it's downtrending. So she apparently had PFTs in the past, and she's gotten worse or had progression. The CT scan did show some early honeycombing consistent with a UIP pattern. So as far as what is next, I believe she is seeing, I think that she's with pulmonary right now. I'm not exactly sure where in the process she is, but obviously if she hasn't established with a rheumatologist, want to get her in with rheumatology. If she hasn't established with pulmonary, get her in with pulmonary. Also, one of the next steps would be immunosuppression. And then as far as would you initiate treatment or refer to transplant, my vote would be both, because her PFTs aren't honestly that significantly impaired. So my suspicion is she's not going to be a transplant candidate quite yet, but you don't want it to get to that point. You want to try to slow things down. So mycophenolate, which is an immunosuppressive agent, was initiated. We did also go ahead and send a referral to a transplant clinic for evaluation for lung transplant. Same thing as kind of with the last case study patient, kind of reviewed vaccine needs, made sure that she's up to date on all those vaccines that can protect her lungs. Also kind of introduced the concept of palliative care for symptom management, which can be really beneficial for these patients. As far as what non-pharmacologic interventions, what role do they play? I really utilize the non-pharmacologic interventions pretty heavily, and that can include evaluating someone for an oxygen need, especially someone who desaturates on exertion, maybe getting them in with pulmonary rehab to increase their exercise tolerance, get them to feeling better, kind of optimize their functionality. This is something that is also going to be required by any transplant center, is that they are utilizing pulmonary rehab and active. Usually it's 30 minutes a day for at least 5 days a week. Vaccines are important as well. And then palliative care is one of the non-pharmacological roles, and just kind of ensuring that our patients' symptoms are being managed and things like that. How do you monitor and adjust therapy? So in terms of the mycophenolate, we need to do lab monitoring. So you're going to want to watch their blood counts. So when mycophenolate is initiated, we need to do CBC with diff and a CMP monthly for at least the first 3 months. As long as everything remains stable, then the protocol at my institution is then to do it every 90 days as long as they're on the medicine. It can really affect blood counts, and so we just need to monitor for anemia and things like that. The other thing you want to watch for is side effects. So are they having side effects to the medication? The primary ones with mycophenolate really are GI, nausea, vomiting, diarrhea. But since it's an immunosuppressive agent, you also do want to monitor, are they, developing recurrent infections? For women on this particular drug, we tend to see recurrent UTIs as our most common infectious complication with it. So it's just something that we need to monitor closely. And then we just adjust it accordingly. So as far as a summary here, just kind of recognizing that diffuse systemic sclerosis is high risk disease for development of ILD, and again, paying attention to those symptoms and things like that, getting in early for lung function tests, CT scans, et cetera, to really monitor early intervention with immunosuppression if necessary. And then, also looking at antifibrotics and the role depending on, are they having progressive disease? Are they having worsening lung function tests, progression of their fibrosis on CT scans, things like that. So it's kind of an evolving look at the whole picture. And then also looking at that timing as far as, referral for not just transplant, but all of those non-pharmacologic things. So getting pulmonary rehab on board, palliative care, etc. So I just want to ask, what your kind of all of these things, what are your key takeaways for both of these? And then as far as this talk goes, how has it shaped your ILD, suspicion management, things like that? Is this applicable to your work? Is this, how are you going to use this on a day-to-day basis? And then in terms of kind of getting in and utilizing some of those tools and those skills, like how confident are you? And what do you feel like you need more knowledge or information on?